as was just said, I'm going to talk today about research to increase access, or what we're doing at least, to try to increase access to substance use prevention among youth. I sit within the prevention research branch at NIDA, and I work very closely with all of the colleagues here pictured on the screen. And even though I have the pleasure of being here today to talk to you, really any of them could have given this talk. That's how closely we work together. So everything I'm going to talk about is really a branch effort. And we fund research. We don't do the research really at NIDA. And so most of what I'll be sharing today is sort of ongoing research that we've supported. And all the PIs of those research projects are also willing to answer questions, and you can reach out to them as well. I'll have 3 different sections to the talk today. First, I'll talk a little bit about some background information on prevention among youth. And then in the second part of the talk, I will share how our prevention research branch is structured and the different portfolios that all of our program officers hold to give you an idea of where we're trying to encourage more research in the future so that we can reach some of these populations of youth who traditionally have been underserved by prevention services here in the United States. And then I will use an example of the HEAL Prevention Initiative to really describe some of the projects that are supported now through the Prevention Research Branch and through the larger NIH HEAL initiative that I think are good examples of sort of this place-based, community-engaged prevention research that we're trying to support more of. But I want to first start with a quote from Dr. Murthy, the US Surgeon General, that I think highlights the importance of prevention in a very simple way. He said this was a quote from the NIH Helping to End Addiction Long-Term Initiative meeting back from 2021. They just held the 2022 meeting. This is from 2021. And he said, people want to prevent illnesses. I have not met anybody anywhere in the United States who has said, I'd rather get diabetes first and treat it versus prevent it in the first place. As silly as that might sound, it is the exact opposite of how we finance health interventions in our country. We put the lion's share of our dollars in treatment. We do very little in prevention. I think that sums up well the main points today that you'll hear me make over and over again. One is that effective substance use prevention promotes health and well-being generally. In addition to reducing or delaying substance use, it just promotes health and well-being, so it's important in that way, while also reducing the need for treatment and ultimately saving lives. And yet there remain persistent challenges in scaling up and increasing access to evidence-based prevention services. So one of the things we think a lot about in the prevention research branch at NIDA is how can we invest in research that we know will help to overcome challenges and ensure that there's wide-scale, equitable access to prevention services. Prevention across the lifespan is important, and we know that. For the purposes of today, many of the examples I'll share are focused on this transition from adolescence to early adulthood because we know it's an opportune time for prevention. So as illustrated here, among a nationally representative population of adolescents, ages 12 to 17, about 12 out of every 100 adolescents reported using substances in the past month in 2020. In comparison, about 60 out of every 100 young adults, ages 18 to 25, used substances in the past month. Alcohol is the most commonly used substance, but we see this increase in substance use between adolescence and young adulthood across all substances. And this is from the NISDA data. I think the stats you saw before were from Monitoring the Future, a little different, but pretty much shows the same thing. So this need to focus on prevention among youth is well known. I don't think this is a surprise to anyone in the room, right? And it has been a focus of prevention research for many years. And yet we know we're still missing a large number of youth who are just not getting prevention services, particularly evidence-based prevention services. And we know that some youth are less likely to get them, for example, youth disconnected from school. So I looked in the NISDA data just to get a better sense of who is getting prevention services. What does this look like in the United States? And again, this is data from the National Survey on Drug Use and Health. And it shows the percentage of youth ages 12 to 17 who participated in prevention services by the type of service and across the years. And you can see here in that top line that school is the most common setting for prevention services. School prevention services in this case doesn't necessarily mean evidence-based prevention service. It just means these are adolescents reporting that they receive some type of prevention service at school, and in this case, it includes a special class, film, lectures, discussions, printed information, or an assembly about drugs or alcohol. So that's a pretty wide range of some type of education in school, right? And here we see it was 79% in 2002, and it's been gradually decreasing in 2019, about 70% of youth receiving one of these things in school. Parents are also a common source of information about the dangers of alcohol and drugs. We just heard about the importance of talking to your kids. Here we do see that over half of adolescents report talking to a parent about the dangers of drugs and alcohol, about 58%. But it's surprising that the other part of that means about 40% have never talked to their parent about drugs or alcohol. But parents and school tend to be the most common source of prevention information youth are getting. And then few youth participate in prevention programs outside of school. So this might include prevention programs through the healthcare system, through primary care or some other form of healthcare. It could include education or some sort of prevention services you could receive through a community-based setting like a community center or the justice system, social services system, et cetera. And we see about 11% are reporting receiving some sort of prevention programming outside of school. So one of the things we've been thinking about is what happens, first of all, if the school that you're attending might not be able to provide or prioritize services for prevention, right? So if schools are, and it makes sense that schools are the most common place for prevention services right now because youth are spending a really large amount of their day in schools, right? So it makes sense that school is a common setting. But it seems that access to school-based prevention services is not the same for all youth. So here we looked at two different factors, again from the NISDA data, just to see, our youth, can we see differences by different kinds of variables, different background variables or school variables? And here, again, these are youth reports, so we're looking at two factors where it represents more about the resources the school has than the youth itself. So here we see that participation in school-based prevention services differs by income, and it differs by the level, by how many activities you're involved in. Schools that serve higher numbers of low-income households are less likely to provide prevention services, right? And then the schools that serve higher numbers of high-income households tend to have seemingly more resources to provide provide services. Again, we don't know if it's evidence-based. The point being that when we leave it to these systems, such as schools, that might not have the primary mission of providing services, it's not going to be the same across all those systems and schools. So with that background and this, I'm really just showing a couple factors here as examples of what we're trying to do in terms of increasing this access to more consistent evidence-based prevention services. So here in our branch, we've been thinking a lot about how can we build research portfolios to address prevention challenges and ensure the availability of wide-scale, equitable access to services, again. For those who are unfamiliar with the Prevention Research Branch at NIDA, we are a part of the Division of Epidemiology, Services, and Prevention, or DESPER, we call it. And DESPER's mission is to improve the nation's public health by promoting integrated approaches to understand and address interactions between individuals and environments that contribute to the continuum of problems related to drug use. And one thing that we're particularly interested in our entire division is how can we fund research that will directly relate to policy and practice, improve policy and practice, not just relate to it, but improve it and make it stronger. And how can we pick out the research studies that are going to lead to something that can be sustained over time in terms of improvement in policy and practice? So some of the major DESPER data collections you likely know about or just heard about in the last talk even are the Adolescent Brain Cognitive Development Study, or the ABCD study, is funded through DESPER, the PATH, or the Population Assessment of Tobacco and Health study, and Monitoring the Future, the Monitoring the Future study. So the prevention research branch is one of the 3 branches within DESPER, and our mission is to support place-based, community-engaged research, addressing gaps in the development, implementation, and sustainability of interventions to prevent substance use initiation or the progression from use to misuse or disorder. The 2 key parts of that mission being really supporting place-based and community-engaged, meaning the right stakeholders are around the table to be able to inform that research. Areas of research we support include efficacy and effectiveness research, which is research to examine the intervention effects on initiation and progression of substance use, strategies to reduce harm, interventions to advance health equity and address the upstream social determinants of health, because we know that meeting somebody's basic needs can impact even the degree to which they might participate in a prevention program. But we also know that access to prevention varies depending on the social environments as well. Research that develops and tests strategies, frameworks, or tools to disseminate, implement, and sustain evidence-based interventions. And this is much of what I'll talk about later today. So just a little bit of a background about the sort of main challenges that we're trying to address in our branch. One is that we know this persistent challenge of there's not a home for prevention oftentimes. Outside of coalitions, the workforce can be unclear. There isn't a main prevention system across the United States where people go to if you need prevention, right? So if, for example, if you have a son or a daughter who is struggling and you know that this would be the best time to intervene, maybe they've used once or twice and you want to give them some sort of prevention program, the places you go to are not set up necessarily where the main mission is prevention often. It's usually the healthcare system or the school or other places where they have another primary mission that they're working on. So the degree to which they can prioritize services, prevention services for substance use might vary across wherever you live, what community you're in, the state you're in even, and how much state funding in that state goes to prevention services. So knowing that this is a problem, we've been trying to think, well, how can we then support research that addresses this problem or at least acknowledges it and can do something, about it? And so we try to fund research to develop interventions that are very specific to settings, and I'll talk about those settings in a minute. But we're trying to encourage more people to apply for funding to fund the research where interventions are developed to target specific settings. They're tailored to those settings. They have champions in those settings. And then we know, when they're working with the particular setting, they have a really good understanding of the populations and their risk trajectories so that the intervention is tailored very well to meet those risk trajectories within that setting or population. So those are the kind of things we're looking for as researchers apply for funding for research through our prevention research branch. The second obvious challenge to everybody in this room, I'm sure, is that there's limited prevention funding. The vast majority of funding often goes to treatment here in the United States. And, the one common example people give is the Substance Abuse Prevention and Treatment Block Grant. About 20% of that is set aside for prevention, and the rest goes to treatment. So we've known for a long time this is a problem, but how to think about supporting research that overcomes this is really hard, right? Like, that's a challenge, because if we put $10 million into developing prevention programs, but they can't be funded or they can't be sustained in communities because they're relying on grant funds to renew them every couple years, then that's not a good investment of taxpayer dollars, right? So we're trying to think through what information would be helpful in the research as we're funding new research in this space that could help sustain these programs, even with knowing there's limited funding. And we think, and what we're trying to encourage, is that research that's grounded in strong partnerships within the community with end users who know what exactly they need out of that program would then be able to help champion the program and find some more stable funds for that program long term. And also we're encouraging a lot of economical research, research on the costs of, how much money do you need to start up this program? How much money do you need every year to continue operating this program? because without that clear information coming out of a research study that develops an intervention, it's really hard to get it adopted. Everyone's heard it takes 17 years to adopt evidence-based practices after they're developed, right? So that's the common saying. And one of the reasons we're anticipating or we think one of the reasons is because of this issue of moving into implementation takes a lot of costs, and we aren't often sure about what that cost is. But that's something we can research. We can encourage research on that. So before we, so as we're looking at all the different projects that are proposed to us at NIDA, we really like the ones that come in with an economic component and are really looking at the economics of the research, the intervention that's being tested. So given this focus on place-based research to develop interventions that can be sustained, that can be scaled within specific settings where they might find a home, where they might be able to live long-term, a few years ago, our branch leadership reorganized the portfolio of work that we hold within the prevention research branch. And it is now organized, instead of around substances or many other things we could organize it around, it's around systems. Because one of the things we realized is if you want to intervene and implement a substance use prevention program within an education system, for example, the people you need to partner with, how that is going to work in terms of implementation is all very different than if you want to infiltrate the healthcare system with a prevention program, right? Or the justice system with a prevention program. The key stakeholders you have to work with are very different, but also you have to consider who's going to implement it. It might be probation officers in the justice system, whereas it might be counselors or school teachers in the education system. So all of those factors really play a role based on the communities, the setting in which the intervention will hopefully live long term. So again, all of this is with the idea of really focusing on funding research that has potential to develop into programming that can last for communities. So here we have currently portfolios in the areas of healthcare, social services, justice, community, so that includes things, we have some research going on in libraries that are developing intervention programs, working with youth who come into the libraries, churches, employment centers, community-based centers, things like that is all grouped into that community bucket here. We have a portfolio of research on policy, and then education, and we're really trying to grow all of the research under these different systems. And each one is going to have different priorities. We've done a lot in education before. As we just saw, a lot of people are working in that space. And so the priorities for the education and what we want to really drive forward in terms of research and innovation is going to look different in education than it will be in the justice system, which has a lot less in terms of prevention of substance use programming. We also have a number of cross-system programs where, again, like half of my time here is spent as a program officer. So if you came in and you wanted to apply for funding, there's a program officer that holds each of these different buckets of research. Many of us hold 2 or 3 or 4 or 5 of them. So you would talk to that person who knows most about that system. But then there are some systems that cut across all these different, or some programs of research that cut across these different systems. And that's the epidemiologically informed prevention. So we're really trying to grow this body of work where we have epidemiological studies, we start to understand, what factors really need to be changed in a youth's life to impact, substance use outcomes and other outcomes, and how can we take the research and really translate that into interventions. HIV research, methodological research, tribal populations is one area of focus. Comorbidity is another area of focus that we're trying to grow, and we have a notice of special interest now out on, so I'm happy to share that. And then there's also a portfolio of work on training. And across all of this work, we are very focused on technology, health equity, and services research. So not just doing the research for the point of the research, but really translating that into services and implementing that intervention into a real-world setting. When applications come in, when we're thinking about which ones to fund, we're really looking at what is the argument for why this intervention in this setting and with this population. So when we're looking at why this intervention, is there a strong theoretical basis? Are there clear mechanisms of action that drive why you think that this intervention is going to impact substance use outcomes? And in this setting, I think a lot of times the setting is not necessarily considered, really. It's just a convenience setting, right? Like, who could you partner with at that time? But we really want to be able to understand how the intervention could be there long term. And so we want to know, can it be funded after the research ends in this setting? Are there strong stakeholder partnerships? Is there somebody in that setting who can champion the intervention after you might leave as a researcher? And then why this population? And that one is really important in terms of, like, is there a critically developmental time period or transition? And how are you addressing the risk factors known within that population, within that setting, right? So the profiles of youth you might work with, or young adults, or adults you might work with in one setting could be very different from another setting. And one intervention might not work across all those different settings. So how are you tailoring to be specific to the risk profiles for that setting? Again, with all of this being to promote dissemination, implementation, and long-term sustainability. So take a breath. That was a lot. It was hopefully, and I was worried, is this going to be interesting for you guys? Because it is talking a little bit about what we're looking for in grants that come to NIDA. But I think it also just showcases this idea that if we're going to be able to increase access to prevention services, then we need to push the needle a little bit, and we need to be able to understand what prevention services work best across multiple different settings, not just the school setting. And in the school setting, we still want to know what works best, what are the best ways to reach all youth in school setting, but those priorities will be very different than the other priorities across settings. So the HEAL Prevention Initiative is a large portfolio of work that I think demonstrates some of the examples of what I've covered so far in terms of this encouragement of place-based research and research that considers implementation and looks at things like economics. So I thought it'd be a nice way to showcase some of this work. And also it's a body of work that we expect to continue growing over time. It's focused on the national opioid public health crisis, which we know continues to take many lives each year still. And it's funded, this work is all funded through NIH broadly. It's part of the larger, very big NIH initiative on helping to end addiction long term. So we've started it just in 2019. Much of what I'll talk about is really new and ongoing now. And so I hope that you'll follow this work and continue to see what comes out of it in the next few years. In 2020, about 92,000 people died from drug-involved overdoses. 75% involved opioids, and 62% involved synthetic opioids, primarily fentanyl. That's the light blue line there that you see spiked quite high from 2015 to 2020. This is among all ages, not just adolescents and young adults. Prevention, of course, is essential to addressing the opioid crisis, but until a few years ago really didn't get a lot of attention. Now primary prevention is one of the pillars of the overdose model by HHS. So disrupting this progression from not using opioids to opioid misuse to then opioid use disorder has the potential to affect millions of lives each year. Millions. So 9.5 million people were misusing opioids in 2020, and 2.7 million people had an opioid use disorder in 2020. So if we could have effectively delivered prevention to these people, we could have prevented a lot of those outcomes, right? And so the idea is, how do we reach that? Of course, we don't know how many people we did reach and already prevent. That's the unknown number, but this gives a sense of what prevention has the potential to do if we can reach more people. So this HEAL Prevention Initiative is, as I said, part of the NIH Helping to End Addiction Long Term, very big, large initiative through NIH. It involves multiple NIH institutes, hundreds of research projects addressing both pain management and improved treatment for opioid use, misuse, and addiction. There are 6 scientific teams based on these topics listed here, and our HEAL Prevention Initiative is just one part of this project, and it's funded under the new prevention and treatment strategies, the one that's highlighted here. That team funds the HEAL Prevention Initiative that I'll talk about today. So the HEAL Prevention Initiative vision is that healthcare organizations and public systems will be able to make evidence-based preventative intervention services available and accessible to all persons who experience risk for opioid and other substance misuse or disorder. And I want to note here that in creating this vision, we thought a lot about, one way to say this is that all persons at risk will have access to. But instead, we flipped that around because it's oftentimes people can't just go out and find access to prevention. Typically, it's the organizations that are providing prevention that are often responsible for reaching these youth. So we're hopeful that that if we start to take this systems approach throughout all of our work, we can rely on the system to being able, the questions become more about how can we support systems to reach people and deliver the evidence-based programs that they can be delivering. We support research in 4 strategic areas. The first is risk identification, which includes research on developmental pathways to opioid misuse, risk and protective factors, and risk assessment tools and screeners to be able to identify who's at risk for using opioids, misusing opioids. The second area is social determinants, health equity, and policy. Again, with this understanding that it's really hard to engage in prevention services and make that matter in your life if you don't have food on the table or you don't have a house to live in. These basic needs need to be met first. Also looking at the fact that even across, when systems are delivering interventions, they're not always able to reach everybody and deliver equitable interventions. So how can we increase the likelihood that that happens? And policy. The third area is on intervention development. And this, I would say, is where we've spent the majority of funding to date, although in some of the interventions we're developing, they're addressing also risk identification and social determinants and dissemination and implementation. So I'll talk a lot more about the HEAL Prevention Cooperative, which is part of this initiative, in a minute. It's very focused on intervention development. And then the fourth area is dissemination, implementation, scale-up, and sustainment. I sound like I've said that a lot. I hope you're not getting tired of it. But again, that's the one area that we really we want to see grow, even within this portfolio of research on opioid misuse. So the HEAL Prevention Initiative includes the HEAL Prevention Cooperative, which is 10 research projects. They're funded through cooperative agreements, and there's a coordinating center that helps to coordinate efforts across those 10 research projects. And the goal there is to produce evidence-based interventions for immediate implementation, or as fast as we can, implement them into the community after this work is over. There's also some other administrative supplement work to ongoing research. There's development research, and there's pilot studies supporting the HEAL Prevention Initiative vision. This portfolio to date, we've invested about $60 million in from 2019 to 2021. About 90% of that funding has gone toward the HEAL Prevention Cooperative projects. So let me talk a little bit more about what that is. As I mentioned already, it is focused on developing and testing 10 interventions to prevent opioid misuse and opioid use disorder among young people ages 15 to 30. And here we really are focused on youth and young adults because of what we've already mentioned before, this opportune time over this transition from adolescence into young adulthood. Here is just providing similar stats as before, but really looking at opioid misuse. As we learned in the last talk, not many adolescents are using opioids. But by early adulthood, they are. So if we want to delay or prevent the initiation, then we want to get to them early if we can. So here, about 2 of all 12 to 17-year-olds out of 100 are misusing opioids, compared to in early adulthood, about 4 out of every 100, or 4%, are misusing opioids by the time they reach 18 to 25 years old. Again, this is the data looking at overdose deaths. So we know that not many adolescents are using opioids, but overdose deaths have increased quite a bit. I'm sure many of you saw the recent article that just came out. Adolescent overdose increased 94% from 2019 to 2020. 94%, from 492 to 954. And it increased again 20% from 2020 to 2021. In 2021, 1,146 adolescents died. Fentanyls were identified in 77% of adolescent overdose deaths in 2021. So it is this fentanyl problem that we're seeing. So the HEAL Prevention Cooperative is focused on, again, ages 15 to 30 and involves 10 very different research projects. The research projects span a number of different settings, and I'll show you a little bit more about those settings in a minute, but they're very diverse. And then NIDA, because these are cooperative agreements, NIDA has a project scientist that serves on, that participates in each of those research projects. And then there's also a NIDA program officer that manages sort of the grant part of each of those research projects. And then we have the coordinating center, and all of the teams working together form the steering committee. So the steering committee has one representative from each of these different teams, and that steering committee governs everything that the HEAL Prevention Cooperative does. And then we are very fortunate to work with a community stakeholder board. This stakeholder board is amazing, and so I feel like it deserves a whole slide on just what they do and how they help us. So the stakeholder board has representatives across all the different settings and systems where these research projects that are developing interventions are taking place, in justice, in social services, community-based settings, healthcare, education, some in tribal nations, and then we have some national prevention organizations that are represented on this board as well. And the board really helps keep us informed of emerging challenges and successes in delivering and funding prevention services across these different systems, telling us that that's not going to work in this system because we're dealing with this challenge, right? So we're hearing a lot of that from our board. Or, they help us to understand how prevention structures work within and across the different states. So if we have an intervention that we're developing for the justice system, for example, but the vast majority of funding that is allocated to prevention in a particular state probably isn't going to fund that, then we know we have to look at a different funding source, right? So things like that, they're really helpful. And even just the structure of how the prevention system works. I know some of you are probably from that system, and I would love to talk more with you about this, but I'm always amazed at how much variation there is across states in the level of different people who have some sort of say or authority over how funding is spent on prevention within the state. Some states have 3 different levels of people you have to go through before you understand where which types of prevention services can be funded. And then in some states there are lists of services that you have to pick from that list. And so how do you get your program, a new program that's evidence-based, how do you get it onto that list? So these are the things that our community board has really been helping us to think through. And then, of course, we're still early in this intervention research, but over time, as we start to have findings about the effectiveness of these interventions, we're hopeful that our board will help us disseminate these research findings to the field in ways that make sense to the field, that the field can understand. So the next 3 slides are a lot of information. I'm not going to go through all of this, but I knew you'd be getting the slides, so I wanted to provide the information. It also has the PI's information. And there's another resource where it has all the email addresses of these researchers who are doing these individual studies. So I wanted to make it available to you. So if you do want to explore or learn more about any of these particular interventions, you can reach out and have that conversation with the team that's developing it. But I did want to just use these next 3 slides to highlight the diversity of this portfolio of work as a whole, of these 10 research projects that are all part of one cooperative that NIDA has sort of voluntold to work together just because of the funding stream that we funded them through, right? So here you can see there are 2 projects that aim to prevent opioid use among Native American youth. One is in rural areas and one is in urban areas. Another project is focused on opioid misuse prevention among school and youth in school-based health centers. There are 2 projects that are focused on preventing opioid misuse among youth involved in the justice system, and one project examining an adapted version of the family checkup to be implemented among rural parents with a history of substance misuse. And you're probably getting the idea already about the diversity, but to summarize these last 4, they span prevention among parents with risk for opioid misuse and or methamphetamine use being served by the child welfare system, a housing first strategy among youth, among young adults experiencing homelessness, so questioning, how much better is this intervention if we provide housing for these young people? Prevention among youth in the emergency department who report opioid misuse, and another study examining the impact of treating behavioral health on the development or course of opioid outcomes. So really different, right? And yet, we're working all together as a team. And I think, one of the questions I had when I first started here at NIDA even was, does this make sense to force people to work together as a team when their interventions are all so different, right? But we've actually discovered that it is amazing. And we are, I think, pushing the needle on things we didn't even expect to push the needle on because of the diversity that this cooperative includes. We've really seen already ways that working together has been able to break down silos across different disciplines within prevention. People who focus on intervention in the justice system don't always speak to people who focus on intervention in the healthcare system or the education system. And now we meet monthly and have conversations with each other about how these intervention studies are going, what can we improve. We met last month and just talked about participant recruitment. And it was really interesting to hear that across these studies, the challenge in recruitment differs a lot, right? Like in some studies, they couldn't recruit males. In other studies, it's really hard to recruit because everyone that wants to be involved in the study is actually just outside of the range of the ages that we wanted to be able to recruit. So we were able to talk through different strategies and methods for recruiting across these different settings and systems. We've also had a lot of conversations just about being very intentional about what's different about this setting versus that setting and being able to tailor it to those settings. And then across these 10 research projects, they've harmonized a pretty large amount of data. So they'll have very common outcome measures, some very common risk factors, demographic factors, like many, a lot of times, even as we've moved forward in the data collection, things have come up and we've been able to sort of say, okay, let's find one item that's similar across these 10 projects where we can, similar enough that we could write a research paper combining data across these 10 projects in the future. And if you think about it, that is how the world of prevention works too, right? Like in every state, there's funding that doesn't, like there's not a different funding stream that goes to education versus justice versus healthcare, right? Like some of the funding is the same and it just has to be allocated across these different systems. And so in that way, we're sort of mirroring what real world prevention looks like too, which I think is really great. So we have some comparable measures that will allow us to pool the data and examine a set of research questions that the cooperative has developed. And then we also have a team, a health economics work group that meets monthly and is talking just about economic measures. So they're looking at, right now, they've harmonized an approach across these very diverse studies to measuring the cost of the intervention startup per participant so that we can start to communicate with stakeholders, with end users about what does it cost to deliver this intervention compared to this intervention. And if you're thinking about society as a whole, that's really important. And then overcoming and learning from COVID-19 disruptions has been a major theme since we started. We just started in 2019. By the time things got up and rolling, COVID hit, right? So the team has been really thinking a lot about how to overcome COVID-19 disruptions and being able to talk to each other about different strategies for doing so. There's a paper the research teams are working on now looking at what are the adaptations that were made that are really great and should be sustained because they increased access or did really great things for research, and which ones were just sort of things we had to do but might not necessarily need to be sustained. So there are a lot of different papers coming from all these topics I'm talking about. And then one thing we want to do in general is just prepare for scale up. And so a lot of the work that our coordinating center is doing is focused on combining information across the studies in ways that provide information that stakeholders need to be able to get this program on a list someplace that it needs to be on, or to get more information about implementation strategies. So there's an implementation overlay piece of the work that the coordinating center is leading, really looking at implementation experiences over the course of the effectiveness research studies. So the HEAL Prevention Initiative has a number of resources coming out that I hope you'll follow and be able to provide us feedback on whether or not it's helpful to you. we have a Progress in Opioid Misuse Prevention Research quarterly newsletter that will launch during SAMHSA's Prevention Week. So we're going to launch it timed with that. That'll have all the publications that we've produced to date through the initiative, as well as just some more information about the initiative. The HEAL Prevention Cooperative webinar series will launch in June, and we expect to have, at least for the next couple months after that, one webinar each month. In June, it'll be focused on the juvenile justice studies and really targeted toward policymakers and practitioners in terms of, why is this research important and what do we hope to get out of it in terms of that relates to practice in the future. And then Women in Prevention Science podcast is going to launch soon after that. Many of the investigators on the cooperative are women, and as we were sitting around the room one day, they said, wow, this is amazing to have so many women involved in an initiative like this. Like, why don't we do something that really, empowers more women to come into this work? And so we decided to launch this Women in Prevention Science podcast. All of the publications, resources, and we meet annually. That meeting is a public meeting. Anyone can come and hear the scientific updates. All those materials are available online and shared through our HEAL Prevention Network. And I'll give you these slides that has a link to where you can sign up. And just to point out the picture here, this is at our last annual meeting that happened in November of 2021. Our director, Dr. Nora Volkov, our director at NIDA, spoke with our community stakeholder board, and they had the opportunity to share with her, there are evidence-based prevention programs, but what are the things that are challenging about using them and implementing them and scaling them up? And they had a conversation with her about those challenges they're experiencing in the field, and that allowed us to think about, okay, what can we change in the research or think about in our research that would help to address some of those challenges? Again, this is just for more information. You'll have these. I want to give a big thank you to all of the HEAL Prevention Cooperative collaborators. As you can see here, it is a very large team, and this is only the list of the principal investigators, so they all have their own teams and their own community stakeholder boards too. So it is really a very large effort. And if you ever do want to talk about applying to funding through NIDA, we can always talk to you about research ideas that you have or concepts. Just reach out and talk to a NIDA program official. Our website lists all of our program officials' names in the prevention research branch and their portfolios. That's a great resource for knowing who to reach out to, or you can contact me and I'm happy to refer you. Thank you.